Um, yes, I think we can start the lesson.
Okay. Well, welcome everyone, and we will go ahead and talk this evening about, or today about some of the mesenchymal tumors in the uterus. We may not get through all of the topic. I have a lot of pictures and a few digital slides, so maybe this will be a topic for two discussions. But I'll begin with the very common things, and we'll go here to that screen here. Whoops, there we go. Let's see. Okay, so mesenchymal neoplasms of the uterine corpus is the topic for this evening. And I apologize, I had intended to have this on a PowerPoint, but I had some troubles with the computers, and the PowerPoint version was destroyed. So I haven't had time to go back and reconnect it. But these are what we're trying to get at. Which smooth muscle tumors are malignant, and what are the key features we use to distinguish those? And the other topic of importance is understanding stromal sarcoma. And then finally, what we say on the report, being very careful with that so that we get the right impact and response from the clinical team. Of course, as we go along tonight, if you have questions, please don't hesitate to speak up or to type a note in the chat box, and we will do that. I'm going to also enable live transcript, so that may make it easier for some of you to understand my English. So there we go. All right, well, next slide. Benign smooth muscle tumors in the uterus. These are the most common things. You all see these whenever you get a hysterectomy from an adult woman. These are very frequent, not usually a diagnostic problem. So the features of leiomyoma is that these are very common. And in terms of what we do in our laboratory to sample these, because most of the cases have multiple leiomyoma, it is not necessary to sample all of them, but we always sample the largest one and any of that look a little bit different, that look unusual in some way, either because of discoloration or hemorrhage or necrosis or something like that. It is possible that benign tumors can have infarcts, even sometimes with adjacent mitotic activity. So that's not always the perfect criterion. So we have to be careful with mitotic activity and necrosis, although those are clearly important features. One of the other things to remember is that the nuclei in leiomyomas tend to have slightly blunted ends. So they'll be rounded or blunt, not pointed like a neural tumor or a fibrous tumor. And that's an important thing. And they're not usually epithelioid, although there is obviously an epithelioid version of this. Another feature to be aware of is the presence of these small paranuclear vacuoles in these lesions. That's another useful marker for smooth muscle that we don't see in stromal sarcoma or in pecoma or most other tumors. Now, I mentioned that sometimes you can get hemorrhage and necrosis in these tumors, and this is an example of what that sometimes can look like. It can be quite concerning. But usually there is what we call a granulation tissue type rim around that. So notice how here we have necrosis in the middle, and then we have this pale zone, which looks like it's beginning to form granulation tissue. and then the cellular leiomyoma tissue around it. So that's the finding that can be a little bit disconcerting, because sometimes you'll get mitoses in this granulation tissue zone. And here's another more matured example where the necrosis has become quite hyalinized or fibrotic. And this is, again, a feature of benign leiomyomas. So the features that we look for malignancy, one feature is a degree of cellularity, but there is also a cellular leiomyoma. So this feature alone does not describe malignancy. These are often not quite as well circumscribed. The cellularity may vary. And sometimes it can look a little bit like stromal sarcoma or stromal nodule. But the other feature here to be aware of is that while usually CD10 is useful for marking stromal neoplasms rather than smooth muscle, sometimes these very cellular tumors can have a positive CD10. So just a little bit of a variant to be concerned about. So here are features that I use in the differential diagnosis. This is from a recent textbook. And you can see that the margins can be fairly circumscribed in both stromal sarcoma or cellular leiomyoma. But the tongue-like projections will be present more frequently in stromal sarcoma. The cellular leiomyomas have a fascicular pattern, meaning the cells have a bundled appearance of areas that are united in their orientation, whereas stromal tumors have a very diffuse pattern. There's not a fascicular or architectural feature to that. The cells are a little bit different. These are more oval, more fusiform, and the vasculature can be quite different as well. Thick-walled vessels would be more frequent in leiomyomas, whereas in the stromal neoplasms, they're usually very thin-walled vessels. And then we've mentioned the CD10. Cleft-like spaces, I think, are not highly useful. I don't use that too much, but that's just a little bit of a view of that here. So here's, I'm not going to show you the growth. We'll just go right here to the microscopic feature. Here's a cellular leiomyoma, and you can see here that the margin is a little bit indistinct. But notice we have in the middle here areas of thicker walled vessels that should not be seen if this is a stromal sarcoma. Another example, here's some of the fascicular architecture that you see, sort of bundling or clustering of these tumor cells rather than the diffuse pattern. Okay, now one of the hard areas sometimes, both for clinicians and for us as pathologists, is when we get leiomyomas that have very atypical, very bizarre nuclei. And it's been debated whether we should use the term, atypical leiomyoma or not. But I think most people now have found that this creates more clinical concern than it should. And so we try to discourage the use of the term atypical leiomyoma. That may confuse them, and they may be thinking they're dealing with a low malignant potential or uncertain malignant potential tumor. And these tumors usually have bizarre nuclei in multiple foci, but sometimes they're only focal. There usually is low mitotic activity, but if you see the bizarre nuclei, it may be worth making additional samples to ensure that you don't have other problems. Now, sometimes we can actually have TP53 mutations in Ki67 increased. And in those circumstances, some people will call this a smooth muscle tumor of uncertain malignant potential. So that's kind of the issue here. So this is what these look like. As you can see, these are very bizarre, wild-looking nuclei, irregular chromatin patterns, variable shapes, maybe nuclear inclusions, and ugly-looking cells. They can have sort of karyorectic cells like this that look like atypical mitotic figures. And if you thought these were mitoses when I put this up, then you would be in good company. However, if you happen to have the phosphohistone 3 stain, PHH3, this would not stain. So in these situations, these are not truly mitotically engaged spindles where the phosphohistones have been exposed, but are simply degenerate, bizarre nuclei. Here's an example at a lower magnification of something that looks like a mitosis and so forth. Now, I do have a digital slide here as well of one of these, which I'll show you here. This one up here. So here you see there's kind of a variable nature to this lesion, some cellular, some less cellular areas. But even at this fairly low magnification, you can begin to see that the amount of nuclear material here is quite striking. And compared to, say, this less cellular area over here, it's even more unusual. Although even at high magnification here, we can see that there are abnormal nuclei in this area. So here's an example where the nuclei are quite uniform in some areas, but then occasionally these unusual, or what we say, bizarre nuclei. Now, I don't know how you translate that into Vietnamese or into Khmer, but this is, you do want to make sure that the communication is clear on this lesion so that the clinician doesn't overreact and think that they need to do some chemotherapy or follow them very closely. These, in general, have a uniform benign behavior. So then coming back here to where we were, the differential for this lesion includes several other things. And so you want to make sure that you rule out leiomyosarcoma, because nuclear atypia is a feature that can lead you to or confirm the diagnosis of leiomyosarcoma if you have the other features like necrosis, like increased mitotic activity, infiltrative border, and so forth. The other tumor that you have to be aware of, and this is an important diagnosis to make, is the fumarate hydratase deficient smooth muscle tumor. This is an entity that is more recently recognized, and it is most often occurring in a germline mutation form. There is some sporadic versions of this that get biallelic inactivation of this gene. But in either case, there are other tumors or other issues that can be involved. And so making this diagnosis is important. One of the conditions is renal cell carcinoma that can be associated with that, especially the germline mutation, some skin tumors and so forth. And the sporadic version is more prone to papillary renal cell carcinoma, particularly the high-grade version. Now, in many older series of leiomyoma with bizarre nuclei, these tumors were lumped together. And so if we were to go back to the early descriptions of leiomyoma with bizarre nuclei, we would find some of these fumarate hydratase deficient tumors. So what do those look like? Well, they look a little bit different. Slide up here. So here's an example, and you can see there's still these bizarre nuclei. So that's not a key feature here. But one of the things that you may be able to pick up on is these eosinophilic bodies or inclusion type of structures, almost rhabdoid type of structures in the cells. And so this is a feature that if you recognize it, you can say, oh, maybe this is a fumarate hydratase deficient tumor. And in that case, you may want to do things like germline testing or other evaluations. Another feature of these tumors is these very thin-walled vessels, sort of staghorn-like structures. And they can have these sort of large macronucleoli as well, as you see here. So those are features that we don't usually associate with leiomyoma with bizarre nuclei, but that are present in the fumarate hydratase deficient tumors. Here again is one of these eosinophilic bodies here that we just talked about. So I will be perfectly honest here that this is a diagnosis that I have only made very rarely. And I think the first time I made it was because my resident said, do you think this could be fumarate hydratase deficiency? And I had not considered it at that point, but she turned out to be correct. And this is what the immunohistochemistry looks like in these tumors. The vascular cells and stroma, the benign stroma will express fumarate hydratase, but the tumors will be negative. This is usually a cytoplasmic stain. So any questions about that? Maybe you're still thinking. If they come up, that's fine. We can come back to this if need be. So another variation on the leiomyoma theme that is still considered benign is has been termed mitotically active leiomyoma. And so this is a smooth muscle tumor without nuclear atypia or tumor-like necrosis that has a mitotic rate that is, you know, between 5 and 15 mitotic figures per 10 high power fields. So it's in that realm where you would find them, probably with some degree of ease, but there's none of the other features. Now, is it a crime if you don't find them, if you don't make this diagnosis? Well, no. But because there's no atypia, no necrosis, it's a benign leiomyoma that has mitotic figures. Now, if you get over 15 and you don't have atypia or necrosis, then you're moving into the uncertain malignant potential group. And so that 15 mitotic figures per 10 high power fields is an important threshold to be aware of. So again, they don't look atypical. Here's an example. Here's a mitosis, here's a mitosis. So we can find several mitoses or things that looked like them with relative ease. And so then once you see them, you have to start counting them. If you don't see them and you don't count them, well, that's not a bad thing. But if you do see them, you should certainly count to make sure that you have not exceeded that. And I usually will count more like 50 fields. It's not just count 10 fields, and if you don't get over 15, you want to sample it pretty well in that regard. Okay, another variation, and this is sometimes a difficult one even to classify as a leiomyoma, is the hydropic type. There's so much fluid in this lesion that it almost looks like a cystic neoplasm, or it may give sort of a pseudo-invasive appearance. It just looks very, very concerning. So here's an example, fairly cellular, but a lot of very soft, spongy type of tissue. Another example, even more cystic degenerative type of appearance with this. And if you look at these under the microscope, very often it's just like this. There's lots of empty space, and then just a few strands of smooth muscle that's identified and occasional vessels. So you'll even wonder if this is a tumor or if it's just a hydropic change that you're seeing. Here's other examples, and you can see this is just very, low cellularity. Here there's more cystic spaces, and then sometimes it'll sort of bundle up the smooth muscle with a lot of intervening clear space in between. Here's another example, sort of hyalinized, and it doesn't look like a smooth muscle tumor because it's not very cellular. But if you do immunohistochemistry, these do turn out to have smooth muscle markers, which we would associate with leiomyoma. Okay, now we get into some more challenging areas. Myxoid leiomyoma. So the hydropic leiomyoma and myxoid leiomyoma can be somewhat similar, but these are lesions where there, rather than edema or hydropic fluid, there's actually sort of a myxoid mucohyaline type ground substance. And they may have features that look invasive. And so the differential begins to include a myxoid leiomyosarcoma. This is a situation where you want to be sure to sample the lesion well. Now, we had a case of a myxoid leiomyosarcoma recently in our laboratory that presented as an unexpected finding. The patient was having a hysterectomy for other reasons, and one of the tumors in her uterus, in her myometrium, was a little bit funny looking, and so it got sampled, and it turned out to be a myxoid leiomyosarcoma. Well, myxoid leiomyomas usually will have a more defined border, but it may be a little bit vague because this sort of myxoid appearance. Here's a sort of a special stain to bring out the increased amount of hyaluronic acids in these lesions. And again, you can see sort of a vague margin that's a little bit challenging. Now, in the case of our myxoid leiomyosarcoma, that lesion had other features to identify it as malignant. Specifically, it had nuclear atypia, cytologic atypia. It had mitotic activity, as well as a clearly invasive margin. Finally, the apoplectic leiomyoma can give you the appearance of necrosis. And so this again may come into the differential with leiomyosarcoma. Sometimes these tumors, they infarct or they become so apoplectic that they actually rupture and have a sort of acute abdomen type of presentation. But more often than not, these may be related to progestational treatments. So here's a gross image. You can see these areas of hemorrhagic infarction and kind of fairly uniform age to most of these. And that's another clue that may tell you that it was a single event that led to that. Here's another one with one that's had time to heal. And sometimes these central hyaline scars can be an indication of the apoplectic event. Here we see the necrosis, a little bit of residual viability of cells around the vessels. Okay, well, another variation is the leiomyoma, and I put this in a different category in the sense because it's usually not a difficult histologic diagnosis. It's kind of an interesting finding to see all this clear space and fatty tissue. It usually corresponds to this yellowish change grossly, but there are other things that can cause that. And I mentioned this because there are occasions where these tumors have been the precursors for not leiomyosarcoma, but actually for liposarcoma. And so if you find something that looks like a liposarcoma, you might look around to see if you don't have evidence of something that looks like this in the background. Well, there are other lesions. We'll just touch on maybe a couple of these. But let's go forward to something that, again, comes into the differential with stromal sarcoma, intravascular leiomyomatosis. And I've discussed some of these in other videos in the past. But these are relatively uncommon. But present very similar to endometrial stromal sarcoma. And so that differential becomes a concern. And it also is true that there are variants where there may be endometrial-like stromal elements that are present, or even glandular elements. But molecularly, these resemble leiomyomas. They tend to extend in kind of a worm-like fashion to the adnexa and parametria, and may occasionally also have sort of a cotyledon-like appearance. So what does that look like? Well, let's just take a look here. So here's an example of one that has sort of extended into the parametria, and it's got little buds and so forth tracking through the vessels. Here's another example showing kind of this worm-like pattern, small nodules and nests, somewhat in a mass, but not entirely. And this is kind of what they might be confused with. So this is an image of endometrial stromal sarcoma, which again has this kind of worm-like pattern of small rounded nests infiltrating in the myometrium. Whereas here with intravascular leiomyomatosis, you'll see that this infiltrative pattern has a more smooth muscle-like pattern. It doesn't have this very diffuse blue pattern with the very small vessels that we associate with stromal sarcoma. Here, these lesions may be in some of the larger vessels as well. Here's another example of endometrial stromal sarcoma, again showing this contrasting pattern with a very diffuse pattern of infiltration. Now we know that these tumors, leiomyomas, do spread, and that intravascular leiomyomatosis may be one of the precursors of benign metastasizing leiomyoma here in the lung. You can see a very benign appearing area of smooth muscle extending out a little bit along the interalveolar septi. This is a benign process. It's associated with, that intravascular leiomyomatosis. One thing which can look similar, however, is leiomyomatosis. And the distinction with this is the architecture. So notice this benign metastasizing leiomyoma. It has a rounded nodular shape, and it's occurring adjacent to the bronchiole. In contrast, lymphangioliomyomatosis tends to occur along the subpleural spaces and the interlobular septi, because it's occurring in the lymphatic drainage spaces, not in the vasculature from the pulmonary arteries. So location can help you. Now, the surgeon should tell you. If he doesn't, you should ask, where did this come from? The configuration, rounded versus sort of, wedge-shaped, may help. But if you're looking at a needle biopsy, that may not be possible. And again, this lymphangioliomyomatosis does not have a high degree of atypia. Okay, well, in terms of immunohistochemistry, this is not usually a big issue, but sometimes for the uncertain ones or the malignant ones, occasionally you can get tripped up if you don't know a couple of important things. So for one, keratin, especially the pan-keratins and EMA, can be positive in smooth muscle tumors. So you've probably seen this, but when it's you're trying to distinguish between an epithelioid leiomyosarcoma and metastatic carcinoma, the keratin stain might be one of your main tools. However, if you're aware of this pitfall, you will avoid doing that. Well, so what helps you? Well, the smooth muscle markers, actin, desmin in particular, or caldesmon, are the things that we use most frequently. These other markers, HDAC8, oxytocin, smooth muscle myosin, these are not even available in our laboratory, so I don't expect that you would use them. Similarly with transgalin. I've mentioned that CD10 can occasionally be a little bit confusing, especially if you're dealing with a cellular leiomyoma. Hormone receptors, of course, can be useful, but they may be decreased if they've done other things. And then we've mentioned the P53 or P16, which can be seen in bizarre nuclei and which may lead you to call the lesion an uncertain malignant potential. We will occasionally do a Ki67 or PHH3 if we want to reassure ourselves that something is not more concerning for malignancy. So here we come, leiomyosarcoma. We'll take some of the rest of the time here to talk about this. So this is usually a tumor in adults, but it can happen fairly early in adulthood. The Myxoid leiomyosarcoma I mentioned before happened in a 35-year-old. That's usually a little younger than you might expect. And usually these are solitary, but some may coexist with leiomyomas. Size is usually helpful, but not always. And the margin of the tumor, less well circumscribed, that should lead you to be concerned. So microscopically, the features that we look for and would consider helpful are the cellularity, cellular atypia, mitotic rates, Now I said over 10, but usually it's over 15. But if you've got these other features and more than 10, you're certainly in good solid ground. And then tumor cell necrosis. You don't have to have all of these features. If you have 2 or 3, that may be enough to push you into that category of calling it leiomyosarcoma. So let's talk about necrosis. Since this is a key microscopic feature, there are 2 variants of necrosis that can be seen and need to be considered. So infarct type necrosis, which is more like what we had with the apoplectic leiomyomas and so forth. This is usually characterized by some sort of an interface between necrotic and viable tumor, where there's this granulation tissue-like response. And the necrotic areas will look more sort of more just dead, they'll just be look absent there. And there'll be some semblance of tumor. Well, I'll show you some pictures. That'll help. Whereas tumor cell necrosis is a very sharp, abrupt transition from viable to necrotic tumor. There's no intervening granulation tissue, and the cells within the areas of necrosis are atypical. Let's go to the next one. So, which is this? Well, this is tumor cell necrosis. There's no transition zone between the necrotic zone and the tumor. We've got perivascular preservation, but then we've got very sharp necrotic tumor. In contrast, what's this? Well, this is infarct-like necrosis. We saw that earlier. A necrotic zone, very mummified or gangrenous type appearance, a pale zone, and then the tumor. Now, both types are possible to be seen in leiomyosarcoma. In general, I would say the tumoral cell necrosis, this kind of necrosis, would be more useful and more definite for likely malignancy. So leiomyosarcomas can occasionally develop dedifferentiation, which would be a very high-grade undifferentiated sarcoma. They may get osteoclast-like cells. They may have other immunohistochemistry markers like DOG1 or occasionally HMB45. And that's because there's a variety of other mutations that are going on here or that are possible here. You can also get BCOR and PanTrek, which are markers of a particular type of sarcoma that we're becoming more familiar with. So you can see that, differentiation between, GI stromal tumor, between PCOMA, between BCOR type sarcomas. These are all things that start to come into the differential diagnosis. Now, the P16 that's positive in this setting is usually not related to HPV, although there are beginning to be described some Epstein-Barr virus-related smooth muscle tumors as well. So this may change over time as our knowledge increases. So it's a very interesting area, not always entirely clear-cut. Well, grossly, here's an example. You can see there's variable necrosis and cellularity and so forth. Here's our tumoral type necrosis. Here's a little bit more infarct type necrosis. So forth. Well, actually, they're calling this tumoral type necrosis too. And mitotic activity, cellularity, a degree of nuclear atypia, as you can see here on the right. These are all features for leiomyosarcoma. Now, how do these behave? Well, these are usually not good tumors to get. However, our staging and microscopic features are not really as helpful as they should be. Now we want to, of course, report size and mitotic activity, the grade, the extent of the tumor, and so forth. But it's not always really clear cut. I have seen people use this nomogram to provide better predictive activity of the likelihood of recurrence. And I'm sorry this doesn't show up very well, but essentially this uses factors like age at diagnosis, size of the tumor, high grade versus low grade, whether there's involvement of the cervix, whether there is any metastasis in the region, pelvis and so forth, or distant metastasis, and what our mitotic rate. And essentially you take this nomogram and line up the patient's finding and then read the points here on the top graph. Then you add up all the points for each of these factors, and that gives you a likelihood of recurrence. Whoops, which you can see right down here. So this is the 5-year overall survival, and you can see it's, well, I guess you can't see, it's really not very clear. But it's, if you have a low point score, you may have 80% survival, whereas when you get scores over 200, you're talking about 10, 15% survival at most. So there's a broad range here. The things that give you high point values are obviously high-grade tumors, metastases, local or distant. But even things like size and age can make a great difference in terms of activity. So I won't go further into this, but suffice it to say that patients with slightly different presentations, age groupings, and so forth could have very similar staging by conventional means, but have very different prognostic predictions based on this nomogram. Well, this is the differential diagnosis for leiomyosarcoma. It's a long one. So I don't expect that you'll encounter all of these, but you can see that, starting with the common variant leiomyomas on down to undifferentiated sarcomas and so forth, and various mutation-related ones like the V-core sarcomas, the GREB1 rearranged sarcomas, and so forth. This is a very broad differential. And so when you see these tumors, don't just assume that because it's in the uterus, it's a leiomyosarcoma. There can be metastatic carcinomas that look like these, especially the epithelioid versions, as well as many other sarcomas and primary tumors, including melanoma. Let's jump back over here and take a look at a microscopic slide here just to illustrate another one of these tumors and just how I would approach it under the microscope. So here we see a cellular tumor. The margin is somewhat unusual, and we have clear-cut areas of necrosis. So at low magnification, we're already highly suspicious that this is going to be a malignancy. Plus, we see it's sort of looking like it's trying to extend out beyond the uterus. So we'll go down and take a look at higher magnification to make sure that this is not some other tumor like endometrial stromal sarcoma or something. Well, here it tends to have a somewhat fascicular growth pattern. We've got high cellularity. We've got mitotic activity. We've got these paranuclear vacuoles, as you see here. That's another marker we mentioned earlier for smooth muscle tumors. And this, you can see the nuclear variability here. Now, looking at the necrosis, this is a little bit of a pale zone, so this may be more the infarct type necrosis in this area. Here's a preservation around a vessel. But then here, notice what's here. So here is tumoral type necrosis. So here's necrotic tissue here. Here's viable tissue here on the left and on the right. So we have both types of necrosis. And that will oftentimes be the case, that you can identify that feature. Let's take a look at another example of this. Here we see again a variable lobulation to it, quite cellular, not as much obvious necrosis in this lesion, much more spindle shaped. And you can see the atypical nuclei here and the fascicular growth pattern. So this could be a leiomyoma with bizarre nuclei. It could be some other type of neoplasm, sarcoma. But this is where we might want to have to do mitotic counts. But here's a mitotic figure. And there are other areas where we'd find that as well. Perhaps you'll see some here. So again, we mentioned that you don't have to have all those features. If you don't have necrosis, the cellularity, the mitotic counts, the atypia, those are all, those would be sufficient usually, and particularly if you have sort of an aggressive, large size and irregular margin. See another one here. I think this is actually from the skin, so we'll ignore that one and go back to the other slides here. So let's talk about, in the few minutes we have left, about myxoid leiomyosarcoma. This is looks grossly different from other smooth muscle tumors, and tends to have an infiltrated border, but perhaps with less nuclear atypia. Now, because of the less cellularity and so forth, you can call this a sarcoma with a lower mitotic rate than you would usually use for conventional leiomyosarcoma. And additionally, necrosis may not be very prominent. The myxoid changes can be somewhat patchy in this tumor, and as we've indicated, the late recurrences are possible. So here's an example. You can see grossly that this looks quite different from the other smooth muscle tumors we've considered. It has a more glistening appearance, and just looks a little bit paler. Under the microscope, here's the picture. You can see variable degrees of cellularity and variable degrees of myxoid change. Here you see there's not a high degree of atypia here. There is a mitotic figure there. And in some, you'll see this very characteristic bluish myxoid material. And here you can see at high magnification, a higher degree of atypia than what was in those earlier photographs. So this is a tumor that, because we've mentioned has late recurrences, is is important not to miss because you want these patients to be followed more closely than other patients. You want them to get follow-up. There may not be a specific treatment for these, but you do want to make sure the patient gets follow-up. So the differential for this tumor, myxoid leiomyoma, hydropic leiomyoma, and the myxoid endometrial stromal sarcoma. So we've mentioned here that the atypia mitotic activity would not be present. Hydropic leiomyoma would not have the atypia or the mitotic activity. And CD10 positivity versus smooth muscle positivity, and a different pattern of invasion somewhat. So this one would be a little bit tricky. If you have the capability to do a JAZ-F1 fusion gene test through FISH or other means, the endometrial stromal sarcoma should be positive for that JAZ-F1 sus whatever fusion change. Okay, well, we've gone almost an hour here. Let's maybe pause here and see if you have questions. This is a lot to cover, but and I didn't expect that I would get through all my slides tonight. Does anyone have questions you'd like to bring up or ask?
So Professor Hassel, thank you very much for your
I can barely hear you. Can you speak a little louder?
Yes, thank you very much. Professor, can you hear me?
Barely. Okay, go ahead.
Yes, so could you please tell me again how to differentiate leiomyosarcoma and endometrial sarcomas in general, especially when the leiomyosarcoma can positive for CD10. So, so in our practice, we don't have the fusion gene testing. So, what are some useful marker for differentiate to entities?
Okay, so the differentiation between endometrial stromal sarcoma and leiomyosarcoma. Well, I will say, first of all, the morphology can be very helpful. So yeah. One feature for endometrial stromal sarcoma is a very diffuse pattern.
Yes.
And the cells tend to be a little bit more stellate rather than spindle shaped. The vasculature in endometrial stromal sarcoma is very delicate small vessels. It's not big vessels. Whereas with leiomyoma or leiomyosarcoma, you'll get bigger vessels admixed in there.
Yes.
And you'll have the more fascicular pattern. Let's pull that up here. With paranuclear vacuoles like these in smooth muscle cells and sort of streaming. Now that this is sort of the fascicular pattern. So this blunt or sort of blunted nuclei, fusiform nuclei is helpful. Now, a problem is high-grade endometrial stromal sarcoma, because usually low-grade endometrial stromal sarcoma and leiomyoma are not a big problem. The high-grade tumors are the more difficult ones, because then the endometrial stromal sarcomas have more nuclear atypia and more more pleomorphism, I guess I'd say.
Yes.
So in that situation, the markers that you have that would be useful would be hormone markers, more likely to be positive in stromal sarcoma than in leiomyosarcoma. It's not absolute, but more likely in endometrial stromal sarcoma. CD10, more likely to be positive in endometrial stromal sarcoma. And of course, then the smooth muscle markers that would be positive, more likely to be positive in smooth muscle derived tumors. So if it's not clear from those, then you're probably not going to be able to differentiate them other than by sending it for the fusion marker. P53 might be helpful because that's usually, would be more likely to be seen in in leiomyosarcoma than in stromal sarcoma. So that might be another one, that P16 or P53, that might be helpful. But it's a hard diagnosis, the high-grade endometrial stromal sarcomas and the high-grade leiomyosarcoma.
In our practice, we often see the H-condensmon and some smooth muscle markers are positive in stromal sarcomas.
Yeah, that's right.
Yes.
Yeah.
So sometimes it's very difficult for us.
Yes,
but in our practice, we often see the CD117 CKIT and CD10 often more often positive in endosomal sarcomas.
Yeah.
Can we use can we use all of these features to differentiate them?
Yes, I think that's kind of where you have to go, these are things that can be useful, so it's oftentimes not absolutely clear cut one between the other, but finding things like diffuse P53 or P16 markers with a predominance of strong muscle markers certainly favors leiomyosarcoma over stromal sarcoma. But occasional tumors may have CKIT or DOG1. These other things.
Yes.
And we'll talk about picomas and some of these other tumors next time, because there are other, and more about stromal sarcomas as well. But so this we won't be done with this discussion, but we're out of time tonight, and I know you all have work to do today to get going. Any other last questions before we have to close?
Hey, hi, Dr. Lewis. Hi. May I ask?
Yes, please.
I want to ask you about the leiomyoma with the bigger nuclei.
Yes.
You mentioned that P53 or P16 can be positive with this tumor, but some doctor maybe favor UMT if the P53 or P16 positive. So I want to ask you, so what is the positive rate of P53 or P16? Can we diagnose UMT for this tumor? And the question two is that can you distinguish between the leiomyoma with the bigger nuclei with the Fumarate hydratase deficiency. What is the useful marker to differentiate between the two tumors?
So the question is, what do we do with P53 or P16 in these leiomyomas with bizarre nuclei? And so I will report them as leiomyoma with bizarre nuclei morphologically, but if I detect a P53 or P16 positivity or mutated status, I will report that and suggest that there's some evidence that these tumors have an uncertain malignant potential, and that in light of this mutation status, that more rigorous follow-up is probably warranted. So we don't have all the data on this yet. So this is kind of an area where you have to guide the surgeon or the oncologist based on your understanding of the biology and your understanding of the stains. It's certainly not every leiomyoma with bizarre nuclei is going to stain for these. And so if you have, this feature, then that puts it in a slightly different category. We know, however, that, from prior studies that this leiomyoma with bizarre nuclei was a mixture of this of leiomyoma with bizarre nuclei and the fumarate hydratase deficiency. Now, it may be that there's another subcategory that will come out of that, which is the P53 mutated tumor with bizarre nuclei or something like that. I mean, whatever name you want to give it. And so identifying that and doing the stains, if you see this, I think is worthwhile. Because I think we do want to be able to identify if these are potentially malignant tumors down the road. Now, obviously, even if it has the P53 mutation, if it's completely resected, they may not have any adverse effects. But if you don't report it and they don't follow up the patient, that's probably the one where it will recur in 10 years and they'll wonder. So I don't think we know exactly what to do with this right now, but I think that reporting it, if we find it, allows us to suggest the possibility for follow-up that might be a little bit more than if it was just a benign leiomyoma with bizarre nuclei. Did that answer your question?
Yeah, thank you so much. So I think that for this situation, we after resection and do the pathological test exam, we can follow up the patient, right?
Yeah, exactly.
Okay, thank you so much for your useful information.
Well, it's wonderful to be with you, and we will we'll wrap this up so you can go on to your day. And thank you for your good questions and discussion. And we will look forward
Professor
to
Hassel, can I have a last question?
Of course, Dr. Hunt.
Could you please explain me about the P53 mutations? So I mean the cut out the mutations of P53. So is it absolutely negative or positive, or I mean in the situations of the negative? So if the cutoff is the 100% or 5 or 10% prophecy is okay?
Yes, so we define the mutated status usually through two patterns,
Yes.
although there's a rare third one, but
Yes.
I don't know that I've ever seen that in a smooth muscle tumor for sure. So the one pattern is diffuse overexpression. So most all
Yes.
of the nuclei,
Yes.
generally greater than 70%, are positive.
Yes.
And the other
70%.
pattern is all the nuclei are negative,
Yes.
but some of your endothelial cells or other epithelial cells, if you have them in the sample, would be positive. So it would have some positivity. So the null status is a difficult mutation, a truncated mutation to identify, and it's a little less frequent one. So it can be more challenging. And sometimes you may not be able to tell if it's a null mutation or a wild type, or if your antibody didn't work. So that's a harder one, but fortunately that's the least frequent one. The other pattern that we see in endometrial serous tumors from time to time is a diffuse cytoplasmic and nuclear staining. And I don't know that that's been described in smooth muscle tumors, but that also is a mutated status that is associated with the ATP53 mutation, at least in endometrial cancers and serous tumors of the ovary.
Yes. Thank you, Professor.
Okay, well, very good.
About
Okay.
Differential mutation in the ovary cancer is cut off 18%.
Yeah.
That is different in the leiomyosarcoma.
Well, 70%, 80%, those are very, very close in terms of visual estimation. So if you want to use 80% in leiomyomatous tumors, that's fine. But I think I don't usually do a quantitation. I don't count the cells. I use my visual impression that, gee, most all of the tumor cells are positive. I think this is a mutated status. And if it's a question, then I may suggest that they do other testing to try to verify that in those tumors. But I don't do that, have not done that in the smooth muscle tumors. All right, well, that's it for tonight. I need to go to bed.
Thank you, Professor.
Wonderful to be with you. Thank you.
Thank you. Good night, Professor.
All right, bye.
Bye bye. See you.